major research projects that aims to monitor and examine perinatal health disparities between different social groups in Canada. It's really great to see familiar faces and names from this talk. So I'm really happy to be here. Okay, so this so I was it's not moving. Okay, sorry. Okay, to use this. Okay. So I was trained as a social epidemiologist. This project started when I came to Canada or came back to Canada after my doctoral training in the States, where routinely collected data sets are widely available and also contain lots of details. And when I started working at McGill, I wanted to, in the field of perinatal and pediatric epidemiology, I started looking into some data or papers to look at the extent of perinatal health disparities in Canada. So as we all know, the reducing health disparities is one of major public and population health goals, as indicated in this WHO Commissions on Social Determinants of Health reported, as well as in Sustainable Development Goals now, and in 2018, PHAG published this national portrait of key health inequalities in Canada. So keeping those aims or missions in mind, I started looking into the data in Canada with the Canadian Perinatal Surveillance System. So the CPSS is the National Perinatal Health Monitoring Program that's developed through the Maternal and Infant Health section in the PHAG. So they don't produce regular reports, but they produce the national portrait in terms of the perinatal health surveillance every 3 or 4 years. So they have primary data sources. They use the vital statistics systems from the StatCan, including live births, stillbirths, and death. And recently, they migrated to the database from CIHI, the hospitalization discharge database, for some practical and the data related issues. So the CPSS reports 27 perinatal health indicators that include maternal, fetal, as well as infant health outcomes, that such as total birth rate, severe maternal morbidity, C-section delivery rate, preterm birth rate, SGA, LGAs, and fetal deaths, as well as congenital anomalies and infant mortality. And those indicators are presented by province and territories, and also basic maternal demographic information such as maternal age and marital status, as well as the calendar year. So how about the disparity assessment in the CPSS then? So CPSS report does not include any information on the extent of socioeconomic or racial ethnic disparities in perinatal health in Canada because of the lack of data available in routinely collected data. So basically, there's no monitoring or surveillance system for disparity issues in perinatal health in Canada at national level. So as we all know, the health inequalities do persist in numerous outcomes, including perinatal health, despite the large and steady reduction in infant mortality in Canada, as well as in other high-income countries that have similar healthcare systems. And in Canada, in terms of the socioeconomic health disparity studies, they are mostly area-based, using neighborhood level income or neighborhood deprivation. And we have even more limited evidence at national level in terms of the racial or ethnic disparities in perinatal health outcomes, despite Canada being highly multicultural and multi-ethnic country. So now we have more than 1 or close to 1 in 4 Canadians are born outside Canada, and also we have those 3 officially recognized Indigenous populations that make 5% of the total population, but we do have very limited evidence in terms of the extent of perinatal health differences between different racial and ethnic groups. So that's how this first project through data linkage was born. So Tracy is on the audience, but we named our project cohort as CanBCC for Canadian Birth Census cohorts. So the objectives of this project were, first of all, to establish a national database that contains detailed information on various socioeconomic and ethnocultural characteristics of both parents and their perinatal health outcomes by linking Canadian live birth, stillbirth, and infant death databases to census, so that we could estimate disparities in perinatal outcomes in Canada by multiple individual level measures of socioeconomic position and ethnocultural background, and also enable us to examine the extent of disparities in Canada over time. So as we all know, the sources, like the Canadian Vital Statistics, served as the data source for perinatal outcomes that were collected from 10 provinces and 3 territories. So the first of the Canadian Vital Statistics database was for live birth. So that includes live births occurring in Canada, not the residents of Canada, not the births to Canadians. So it contains maternal, paternal, and newborn demographic information. The residential area, codes both for administrative and health regions, and as well as birth characteristics that includes gestational age and birth weight. And also maternal marital status and birth history, including number of ever live born and number of ever stillborn babies. So, and in Quebec, exceptionally, the birth registration data includes maternal education and mother's mother tongue in Quebec. So that's the only province where the socioeconomic indicators are collected in Canada. So from the live birth database, the perinatal health outcomes that we could create or extract include gestational age at birth as a continuous one, as well as preterm birth or term birth or postterm birth as a categorical variable. And also using the birth weight with the gestational age, we could calculate birth weight for gestational age and classify them into small for gestational age, appropriate for gestational age, or large for gestational age. So for stillbirth, again, it collects all stillbirths occurred in Canada rather than events of Canadians. So the stillbirth definition used in Canada is birth weight greater than or equal to 500 grams or gestational age at 12 weeks or later. And in Quebec, the only birth weight criterion used to identify stillbirth. So the information available in live birth database is included, plus stillbirth specific information is contained. So for perinatal outcomes that we would extract includes stillbirth, yes or no, and also timing of stillbirth, including before or during the labor, as well as causes of death are captured. So from the VitalStats death database, we could identify infant mortality. So that all the live births information plus the death specific information, so that we could create infant death, yes and no, and also the neonatal, post-neonatal mortality, as well as cause-specific death using ICD codes. So as the CanBCC name implies, the source for socioeconomic and racial ethnic data was Canadian Census long-form questionnaire database. So the long-form questionnaire, as you are all aware, collects very detailed information on demographic, socioeconomic, and racial ethnic characteristics of all household members. And the long-form census is distributed to 20% of the enumerated private household in Canada and 25% in the 2016 census. And also for those that live in First Nations communities and in remote and northern areas, the 100% of the enumerated households get the long-form questionnaire. So the consistent questions or highly consistent measures captured in the long-form census questionnaire provide us the comparable estimates of disparities across different regions and over time in Canada. So more specifically for socioeconomic characteristics that we focus on include marital status, including common law partnership, and also highest level of education. That information also includes the place of education completed, as well as the field of the study. For occupation, it is open-ended, but also it captures the industry and work activities, as well as number of hours worked. And for income, we could have source-specific individual level as well as family level income. And for housing characteristics, the ownership is also measured, and also the dollars spent for the rent and the mortgage, so that we could have an indicator of housing affordability. And also the housing information includes the number of rooms and also the housing conditions that require repair as well. For racial and ethnic characteristics, so basically the self-identified ethnicity is measured that includes Indigenous status. So the three groups specified, as well as the First Nations, the registration status, or on versus off reserve residents can be also identified for Indigenous population. And it also asks the country of birth for their own, as well as their parents, so that we could have the generational status for immigrant populations as well. And for those who are landed immigrants, we also have the information on when they became the permanent residents of Canada. So this is basically the cohort design that we used for data linkage. So the census date for 2006 was May 16. So our target population was all births occurred during the 2 years prior the census date. So that was our target population. And for infant death, we followed up to 1 year to identify, to capture all infant death events. So we did both deterministic and probabilistic linkage for 2006 and 1996 CanBCC cohorts. So the initial matching factors included infant date of birth and sex, as well as mother's and father's date of birth and postal code. And once those were matched on those basic variables, then we look for the long-form questionnaire and include it in our CanBCC. In the case where no linkage, no link found, or multiple linkages were found, then we used several other variables for secondary matching, including for 2000 cohort, the names that were captured as image were also used, and for Quebec only, mother tongue was also used as a secondary matching variable. So same, the design was applied for 1996 CAN-BCC as well. So we reported the census the population characteristics for 2006 CAN-BCC, but also included information on 1996 CAN-BCC. So overall, so the key difference between the 1996 CAN-BCC versus 2006 one was that 1996 cohort did not include Ontario due to the incomplete birth registration, which was very common at that point. So, and also the names were not used as a linkage variable in the 1996 cohort because of the unavailable image data of the names captured. So these made us be challenged in terms of looking at the changes in disparities over time in Canada. So with another CIHR grant, so we created another CAN-BCC cohort called for linking 2016 long form census questionnaire. So for this cohort, we had the StatCan had SDLE established so that the data linkage could be done readily and more effectively and efficiently through the DRD. So because the DRD does not contain the stillbirth, because they were not the life residents of Canada, so we did the data linkage in two different steps. So first of all, for live births from the DRD identified, and then from the birth record, we identified mothers and fathers from the DRD for linkage, and then once they were found, we linked them with the census record. For stillbirth, we started with the stillbirth record to identify mothers and fathers of stillbirth, and then found them from DRD so that we could link to the census long form questionnaire database. And that's created the 2016 CAN-BCC cohort. So what's new in the 2016 CAN-BCC? So first of all, the income data were directly from the text file linked. And for 2016 CAN-BCC, we used 100% probabilistic linkage at SDLE by the StatCan data linkage algorithm matching the individual level data. So that led to the increase in the overall linkage rate, but potential increase of the missingness because within the DRD, the unit is all individual. So we have some missing data for mothers or fathers, depending on the availability within the DRD. And also, there is some variation in sharing the complete data across provinces, particularly for stillbirth in BC. So it requires several sensitivity analysis or even data simulation as a potential consideration. So this table shows the overall linkage rate as well as some characteristics. So we have about 97,000 the live births in CAN-BCC and 135 or so in 2006 and close to 200,000 in 2016 CAN-BCC, and 97% of them are mostly 97% or so from each cohort. Each cohort were singleton births. So the linkage rate, as we expect, is much higher for live births, and also, but very relatively lower for infant death. But the infant death linkage rate went up. Oops. Sorry, the slide was moving on by itself. So, okay, so So I just like to draw your attention to the lower linkage rate for stillbirths and infant death. So the highest stillbirth linkage rate for 2006 came from some manual findings of stillbirth record that we put a lot of time and efforts to. But with the probabilistic linkage at SDLE, the stillbirth linkage rate went up in 2016 cohort. So these were basic demographic information of the population. So the maternal age increased over time as expected, as well as the immigrant mothers in population in proportion, they also increased over time. We also created the CAN-DCC cohort weights in order to ensure the representativeness of all births events in Canada. So basically, to represent our target population for the study period, and for census data, it come with its own sampling weights to account for non-response. And also our linkage is not perfect. So the bootstrap, the replication weights were created at Statistics Canada so that to incorporate both census weights and the imperfect linkage so that we could apply in our variance estimation. So these show the perinatal outcome rates in Canada over the 3 cohort. So for the preterm birth, it was slightly went up from 1996 to 2016, but SGA rate decreased over time, and quite stable LGA rate in Canada for non-fatal outcomes. And for fatal outcomes, as you may be aware, the stillbirth rate in those 3 cohorts went up from 5.2 per 1,000 births to 7.4 per 1,000 births across those 20-year period. But the infant mortality decreased from 5.4 per 1,000 live births to, sorry, I lost the screen sharing. Do you see my screen?
No, it should be in the top right.
Yeah, I mean, it just disappeared. I don't know what. Sorry about this. This doesn't. Okay.
There should be a row of functions, and one of them says share.
Yes, it's doing something.
There you go.
Okay.
You just have to scroll ahead.
Yes. Okay. Okay, so do you see the screen now?
Yes, it says perinatal outcome rates.
Yes, right. Okay. Okay, so so that's the overall the outcome rates in 3 cohorts. But feel free to interrupt if you have any questions. I didn't mention that. Okay, so just as an introduction of like what we have done using those cohorts. One of the studies that we published or looked at was the black and white disparities in preterm birth rate, comparing Canada and the US as well. So it was by Britt when she was a postdoc here, and I believe she was at SickKids as well for some time. So as we can see from this gestational age distribution by black and white between US and Canada, we see a little bit of the shift toward the earlier gestational age at birth in US in both black and whites. So in terms of the preterm birth rate, the Canada does have lower preterm birth rate in both black and white compared to US, but the black mothers do have higher preterm birth rate. So we looked at the disparities between Black and white in preterm birth rate on both relative and absolute scales. So for the adjustment, we adjusted maternal age, marital status, maternal education, birth order, infant sex, as well as paternal information, missing or not, and maternal nativity. So for fair comparison, we standardized the Canadian estimates using the US the estimates so that both populations become comparable. So as we see here in US, those expected Black-white disparities were observed in both relative and absolute scales. But in Canada, we also observed a similar degree of Black-white disparities in preterm birth after adjusting for those covariates as well. And for some other the project, we looked at whether there's any adverse birth outcome differences between foreign-born and Canada-born mothers, and we found the Canadian, like foreign-born immigrant mothers, had lower rates of adverse birth outcomes, but slightly higher SGA outcomes in 2006 as well as 1996 cohort. But importantly, when we looked at the race ethnicity specific of the mother, we found quite a bit of heterogeneity across racial groups in each of those outcomes that we looked at, except those fatal outcomes, because we have very low power for fatal outcomes. So even though in this major, like a primary analysis, we adjusted for maternal ethnicity, but we thought it's important to see the racial ethnic group specific associations in order to see whether they are homogeneous in terms of the association with nativity. And we also looked at various socioeconomic disparity indicators for different outcomes, as well as in indigenous populations, and for some paternal specific information, whether having the paternal data missing has any implications or associations with adverse birth outcomes, as well as the father's education per se has any association with adverse outcomes as well. And finally, also, we looked at whether having two immigrant parents versus only mother being immigrant or father being immigrant creates any differences in birth weight distribution. So what's ongoing with the 2016 cohort, recently the data became available. We are looking at temporal trends in socioeconomic disparities over the 20-year period using the maternal education and family income as specific SEP indicators. And also we are looking at housing unaffordability and adverse perinatal outcomes. And also we try to decompose the association between adverse birth outcomes and mothers' foreign-born status, and quantifying the contribution of specific the key socioeconomic indicators or demographic characteristics of the mother and the baby. So based on our observation of differences in perinatal health outcomes by maternal nativity, we started another data linkage project. We named it as MIME cohort for migrant maternal and infant morbidity and mortality. So this MIME study aims to, again, create a national database that contains information on perinatal health indicators, as well as immigration details and pre-migration contextual data for immigrant mothers in Canada, so that we could study the post-migration perinatal health by all immigrant subgroups and also by maternal country or region of the origin to determine if the health immigrant effect applies equally to all subgroups. And also, we aim to address the role of gender in immigrant mothers' health by looking at how pre-migrant society level gender inequality information or characteristics affect immigrants' perinatal health outcomes. So besides those vital statistics database that we used as perinatal health database in CanBCC, we included them, but additionally, we linked the IMDb database, which is an administrative immigration data for all immigrants admitted to Canada since 1952 and non-permanent residents since 1980. So this IMDb has an information about immigration category that was identified since 1982. So that captures whether the immigrant class was economic class or family class or refugee. That IMDb also contains characteristics at landing that includes country of origin and also age at landing, knowledge of official language, and as well as level of education at the time of landing. And for MIME, we also linked CAI hospitalization discharge database. So which is, as we all know, administrative hospital discharges that include stats and also some sign-outs and transfers. And some provinces and territories also captures the day surgery in DAD as well. And that is available from 1994 and on, so that we could link to. So for pre-migration contextual data, we have collected country-level indicators of gender inequality from publicly available sources, such as UNDP data sources. From that, we extracted the gender inequality index as the overall score, as well as in order to capture political empowerment for women, we relied on VDEM Institute, so that as a VDEM female empowerment index, so that for each country, so that we can identify how much of female empowerment is present at country level. Also, for reproductive health rights, those reproductive health rights index was used to construct the international to have the reproductive health rights within each country that we benchmarked to WHO's reproductive health indicators. So for that measures, we would include contraceptive prevalence, maternal mortality ratio, percentage of births attended by health professional, and total fertility rate, and also percentage abortion-related admissions. So for the MIME cohort, we linked all the live births and also linked to live births linked to infant death, and also we linked all those live births and the link to infant death to the IMDb, which include approximately 1.4 million mothers, as well as the stillbirth to create the MIME cohort. So this linkage was done 100% probabilistic linkage at SDLE again. And if the mothers were identified within IMDb, then we classified them as the birth to immigrant mothers. And if not, then for Canadian women, and we also cross-classified with birth records. So for the MIME, we included some additional databases that we created, the country-specific contextual data, as well as the discharge database. So when we have, so the database, the hospitalization database were linked for both the mothers as well as the children. So for when we use the mother's hospitalization discharge data, then we could look at the pre-migration context and migration characteristics on maternal health during pregnancy and perinatal health outcomes, as well as postpartum health of the mothers. When we link those different databases to the children's hospitalization record, then that would allow us to look at pre-migration context and as well as migration characteristics, if associations with child health trajectories in Canada as well, particularly, I mean, within the children born to the immigrant mothers. So this shows the characteristics of immigrant mothers by their immigration class. So for economy class and family class refugees, as well as immigrants before 1980, where the class or the immigration type information was not available, and also the Canadian-born mothers. So as so there were close to 8 million births from 1993 to 2017. Oh, I forgot include the time period on this slide, but I included that information on the data linkage or the cohort creation slide. So this captures the birth from 1993 through 2017 in Canada. So those 8 million babies were born to 4.5 million mothers in Canada. So these are the characteristics by the types of immigration. So economy class, family class, refugees, and Canada-born. So clearly, the percent mothers aged 35 or older at birth were highest among the economy class immigrant mothers, and also lowest for among Canadian women. And so the immigrant mothers also were less likely to be unmarried, or so the more likely to be married compared to the Canadian-born women at birth. And clearly, the immigrant mothers, their partners are more likely immigrants or foreign-born as well. So what we could do, or what we are doing using MIME cohort, is to disaggregate immigration populations by different immigration characteristics. This graph shows the relative risk or risk ratio of adverse birth outcomes among immigrant mothers compared to the Canadian-born mothers by immigration types. So the blue dots show the overall the risk ratio when all immigrant mothers combined. But as we can see, there are some heterogeneity within immigrant populations, highlighting it's important to disaggregate immigrant populations by different characteristics. So we are currently doing some analysis and mostly data cleaning for hospitalization data, and also the contextual data database creation. Besides that, analytically, we are looking at perinatal outcomes specific to refugee subgroups now. So we have different types of refugees depending on their sponsorship, such as the government-sponsored or privately sponsored, as well as in Canada refugees or asylum seekers. And also within economy class immigrant women, we could identify whether the mother was a principal applicant or non-principal applicant as an indicator of gender dynamics or empowerment within family. So, so just as a summary, in terms of the opportunities through the data linkage, the ways to examine and monitor the perinatal health disparities in Canada. So we have created unique and novel data using data linkage. So those data sets would be the first national level perinatal health data. And also uniquely, we could, in CanBCC particularly, we created infant, mother, and father triad as a unique source of data. Also, we could, also using those linked databases, we could systematically examine the perinatal disparities that were not possible in the past at national level, including socioeconomic disparities across different indicators that could also reveal some differential mechanisms depending on SCP indicators, and also ethnic disparities for the conventional and as well as the categorizations, and also some Canada-specific subgroups as well. And importantly, using MIME data, we could disaggregate immigrants again, and also we could link the contextual data as well, so that we could understand whether the post-migration characteristics versus pre-migration characteristics that are more influential or are better associated or differentially associated with adverse birth outcomes and also health trajectories. And as also an opportunity those databases could be linked to other data sources, such as we could follow up of those cohort members, finding them from different also admin data sources, and also some other databases such as air quality and regional health services data also can be linked to. But there are challenges as well. So again, those routinely collected databases are not collected for research originally. So it has some limitations that include incomplete registration or incomplete sharing of data across provinces and territories, and also over time. And inconsistent data elements and also variations in definition also gives us some challenge. And this recent changes in linkage process at StatCan through SDLE that leads to higher linkage rate. But as I pointed out, it was all individual record based. So when we linked, it creates a little bit of increase in linkage in missing data as well. And it is expensive for linking the data, the linkage process, in both time and resources. And also, particularly for fatal outcomes, it's at national level, but we still have not enough power, statistical power. So as an overall summary of research conducted through data linkage, so I believe that advantages outweigh limitations for monitoring and quantifying disparities in perinatal health across population subgroups. So it's expensive, but probably much less expensive than primary data collection. And again, inconsistency in data collection and sharing is a challenge, and also multiple stakeholders and organizations to cross-check for data availability and collaboration also is an additional challenge or step to build upon to create a database and use the data for research as well. And logistically, the data access only restricted to RDC kind of like imposes some challenges, particularly for trainees who really who are not very happy to be like stuck at RDC for their research. But so this centralized data linkage system at StatCan that facilitates creation of different data sets in efficient ways. And also through the data linkage, we create publicly available data for other researchers using taxpayer money. And as I also said before, there's plenty of different research opportunities with existing and also further data linkage national and do some national comparison over time, as well as some international comparison as well. So these are our research teams and the funding source from McGill and Statistics Canada and U of T and also University of Montreal. And I thank you for listening to me. And it's way past over the 40 minutes limitation of presentation, but I welcome any questions or comments.
Thank you very much, Dr. Yang, for an excellent talk.